we are seeing a longitudinal relationship approach to medicine being fragmented into transactions. And this happens when you get people that run businesses by spreadsheets.
Welcome to the Scale My Clinic podcast. I'm Sachin, co-founder of Scale My Clinic, here to help general practice owners build thriving, profitable and efficient clinics. Together with Todd, we bring you actionable strategies, inspiring success stories and expert insights to transform your practice. Let's dive into today's episode and take the next step to improving your practice. Okay, welcome. So today we're going to be talking about some of the headwinds facing general practice as we come into 2025. This session is going to be about the headwinds, and then we're going to talk about in a future podcast about how we can, as general practice owners and people who work in general practice, how we can address and tackle some of those headwinds. But let's get started today. So Todd, tell us, I've written down a few thoughts here, and I've thought about it maybe politically, economically, socially and technologically, but there may be other things you want to cover. Maybe let's start with our favorite people, the politicians.
Politicians. So it's interesting. I mean, if you look at the last 18 months in general practice, or even just post-pandemic, the rate of change has accelerated dramatically. And there's been some sort of macro trends that are all playing together. So the first thing is that we're really not manufacturing enough GPs onshore. Like we've just sort of given up. We've abandoned the idea that we'll ever get to do that. That does concern me on a lot of levels, but we won't go too much into that today. And so we've decided we're going to help make this up by importing doctors from other countries, increase the breadth of where people can come from and how easily they can come from those other countries. And then we've decided that we're going to backfill a whole bunch of sort of task-layered problems and give those to other professions. So, for example, you're getting pharmacists that are contributing a lot more to healthcare and doing a variety of very small, well-defined areas. Well, we're going to say they're well-defined. I'm not sure they are that well-defined. There's a lot of private services now. And what we've seen is a drop in the number of general practice services delivered in the community. That is quite a substantial number. We don't really know how that's going to pan out yet, but it does look like there's a lot of headwinds that are coming to bear on what we are currently doing in general practice, and we need to be thinking a lot about all of those.
And our politicians have they've been around the other side of the world. They've looked at that beacon of excellence, the NHS, and in their eternal wisdom, they have decided to copy that model in some way, shape or form. We've got this creation and this what seems to be a willingness to create what is essentially fake doctors. And that model, in the UK was rejected by the BMA. Recently, the British Medical Association has now come out fully against physicians' associates. I know from speaking to people in UK general practice how much they disliked that. The reality is there are versions of that coming here.
100%.
And so that's going to be a challenge that we have to address. So let's talk money, economics. What are the economic headwinds facing general practice?
Well, I think the reality here is everybody wants to be a GP, but nobody wants to do the work to actually get the qualifications. So let's just, you and I, be really clear that a GP is a vocationally registered GP, so a specialist GP. One of the problems is there's a whole bunch of people using the word GP that are not GPs. And the other problem is they're kind of pretending that they are running general practices, but in fact, that's completely not what they're running. So there's a lot of, and they're doctors and doctors. Now, look, I love pharmacists and I love practice nurses and I love nurse practitioners. They all have really important roles to play in clinics, but they aren't VR GPs, right? All of the impacts that are made in communities in regard to community health are measured around the work that VR GPs do and that specialist GPs do. And so I think it's really important that we just don't pretend that these other things are a like service. So, for example, pharmacists providing scripts and then retrofitting a diagnosis into the scripts. There's that saying, if all you have is a hammer, then everything looks like a nail. On the one hand, we're saying, we need to be really, really careful with antibiotic stewardship. And there's been decades of work done in medicine on this. And then on the back end, we hand over prescribing rights to a bunch of new people who happen to have boxes full of the stuff that they can make a diagnosis and then dispense at the same time. Now, previously, if GPs wanted to do that, curiously, that was a conflict of interest. It isn't a conflict of interest for a pharmacist who has exactly that to say. Not only that, but they can do something they call companion prescribing. When they give you the antibiotics, how would you like some cranberry juice or cranberry tablets as well to go with your UTI? And then on the way out, would you like to get some other bits and pieces retail. Try doing that in a general practice. You can't even sell a piece of gauze to somebody if you're bulk billing them. Absolute BS that we get exposed to time and time again with this. It's really, really inappropriate. And meanwhile, the public are fed the lie that this is an equivalent service to seeing your GP, getting a proper consult in a clinical setting, not a retail setting, a clinical setting where nobody's trying to sell you anything. They're actually seeing you just to try and disentangle what your symptoms are and then actually work through a thorough process to actually arrive at a diagnosis. And treatment may be some of that, maybe some of what we get to, but it may also not be that you end up with a prescription at the end of that, or indeed a prescription that you need to fill at a pharmacy. I really am frustrated that that has been retrospectively engineered as if it's somehow a proxy for the work that's done in general practice. Hey listeners, are you a general practice owner wanting more profit, more time freedom, and a dream team to help you get there? At Scalmo Clinic, we've got just the solution. Visit scalmoclinic.com and click Book a Practice Growth Call to talk to one of our practice growth consultants and receive a practice growth plan where we'll walk you through a personalized plan, the tools and help you'll need to deliver on the practice of your dreams. Whether you're looking to improve your existing practice or you're just about to open your first clinic, we're here to help. That's scalmoclinic.com where you'll find the purple button to book a practice growth call. It's free and takes around 20 to 30 minutes. We don't work with corporates or not-for-profits. We're only for privately held general practices in Australia. See you there.
Yeah, I think there's a complete lack of transparency to the public, right? It's obviously being spun as this can now be done at the pharmacy or whatever. But the reality is there are a lot of services that there's a reason that doctors are trained for many years, and GPs in particular have specialist training because we are specialists at undifferentiated presentations. And we all know of patients who've come to us with I just need this, doc. But when we've peeled back the layers, we found something quite different. Cool. So tell me, so we talked about political and economic. Let's talk social.
Right. Well, I think, the technology is enabling social behaviors, right? So we are seeing a longitudinal relationship approach to medicine being fragmented into transactions. And this happens when you get people that run businesses by spreadsheets, the kind of the money guys, when they get involved, sometimes what happens is you start getting little Excel cells rather than the work that is done in general practice, which is importantly longitudinal and ideally with the same doctor with a backup of other doctors in the same environment. That's by far the best. When it's transactional and there's pieces being done everywhere, that is a problem. And so what we're seeing now socially is a really interesting phenomena where there are a lot of private services provided online. And so, that might be as simple as medical certificates. And I'll be really honest here. I think there's a really good opportunity for us all to say we should just self-certify. It seems ridiculous that you have to go to anybody to get a certificate, pay $25, never even meet the person, not even a rudimentary examination. It's really doctor days off, but not doctors now. And so the private layer, what that does is it removes a layer that people aren't even aware is functioning. So the MBS, the Medicare Benefits Schedule, dictates who can see you for what problems in what location. And people don't understand how much protection that has afforded them over the years because you might be having a digital consultation. It might be synchronous. It might be asynchronous. And say you're a woman who's actually getting advice on fertility or maybe on some other areas that are specific to their needs, could be hormone replacement therapy. They could be talking to a hospital-based doctor that's stuck in the training program for neurosurgery that hasn't talked about any of those things for a long time, but they're actually providing that advice because it's fully private. There's no protection from the MBS whatsoever. It could be somebody that has zero experience in that area, but that's okay because you're conducting a private consult and you're there for a script. Odds are you're going to get a script. That's how it's working at the moment.
I have a confession, Todd. So years ago, when the practice was full and the patient had to come in for certificate and they pooed themselves in my room.
Not metaphorically, literally.
No, yeah, not because I was scary, but because they had a form of gastro. And so they had diarrhea whilst in my room because they had to come and get a certificate. And it was really horrible. And then they left, and then we had the leather, like what's now known as vegan leather chairs. So there was a wet patch on there. And I think you have to laugh because it's so stupid that someone was so sick and they had to make their way into the practice. It was just wrong because they couldn't self-certify. And it was actually from that years ago, because the technology didn't exist to be able to organize your certificate online with your practice. So I actually years ago set up something called Dr. Sick Note, like 10 years ago, to try and solve that problem, to try and create capacity in our practice. And I think I was trying to solve a problem, but I was obviously at the early curve of a whole other problem. I've been involved with that for years and years and years. I gave it away early on, but it was just to solve a problem and make it accessible. I think for the last decade, pretty much, there has been that trend looking for accessibility, and those who can demonstrate accessibility will have prominence in the market. I think that's a headwind because there is this narrative throughout that GPs are too busy. That's been going for the last 3-4 years, ever since the pandemic, really. And so that headwind and that just assumption at the patient end of GPs too busy, I'll never get in. That's the real headwind now, because that is ingrained in much of society, that I can't get into my GP, even if it's not true, because people shortcut.
And Sachin, on the back of that, so most people would assume there are more pharmacists in Australia than general practices based on the kind of the stories that the Guild regularly shares and conversations around accessibility. And the reality is there's just under 8,000 general practices in Australia. There are less than 5,000 community pharmacies in Australia. So actually, that's not true. And I think the other thing that, just coming back to the point you made earlier, is when something is over-engineered for a financial return, that's where I have a problem with it. So we take the medical certificate thing, and the same thing is true for medications or prescriptions or any of those things. What happened is these are now owned often by private equity or venture capitalists. And so they're really a financial game. They are primarily a financial metric that they're looking to achieve. And what they do is they stretch the thinnest veneer of clinical expediency over the top of it that just allows it to get through the regulator. And so guess who the bunnies are that are the ones that are providing that human shield of the clinical excellence layer or the clinical layer on top? It's people that often don't even know the risk that they're exposing themselves to. So APRA has been really clear on standing up against asynchronous consultations with patients that are unknown to you. Same with telehealth consultations with that. But meanwhile, there's an endless line of people that are happy to bolster their income just a little bit, take these risks because they're unaware of it. And mostly they're going to be doctors that are not working in that setting in general practice because they know that excellence requires time, effort, and it requires you to actually interview a patient, if not examine them in most cases. And that is just too much trouble for the financial engineers. That veneer would be way, way, way too thick and too costly. And so what they want to do is bring it back to the cheapest service provider, offering the minimum standard that's required to get through all of the regulatory hurdles there. That's the problem I have with this.
Absolutely. So we've talked political, economic, social headwinds. Let's talk technology. What are the technological headwinds?
Yeah, the technological headwinds, regular general practice is not well geared to address these demands, I think. And so we probably need to get away from our mindset of 9 to 5 working and maybe not even weekends. We need to react to this because we do have the ability to offer asynchronous consults safely to people that we know really well from our practices. Everybody's got a computer in their hand all of the time now. And so we are seeing some technological gains even in recent times with the main software providers, the clinical platforms, now having a version that is usable on a phone that will be a cut down version of the main software tool, and also people being able to do telehealth fairly easily from that environment. The payment gateways have started to catch on and again be able to integrate payments back into the practice management software. So we are starting to see some of the arrangements because, we don't have the, I'm going to say luxury, but we can't ignore the fact that we also need to have a good quality patient file that does communicate with Medicare benefits schedule, that does communicate with other parts of the health system, getting letters to hospitals, receiving letters from hospitals. We're not able to just say, we're just going to write a referral. We don't really care what comes back, because you and I know those things need to be read and actioned no matter what, whether you originated the referral or not. So for general practice, we need to make sure we're not the bunnies that are doing all the unpaid work here, actually collating and editing the file to make sure that it's appropriate for patients, because in a lot of cases, that is actually what happens. And so the technology now exists for general practices traditional general practice to participate in all of these services, but offer a much, much better version of them versus these cut down versions, then I'm just going to say they are financially engineered for investors. That's primarily who they're rewarding with those business structures.
Absolutely. Actually, while you were talking, I was just reminded of a story I saw online of a practice where they've been inundated with people coming in for injections. They've been prescribed by online services, and they've just assumed they can just go to the GP practice and ask the nurse, can you just administer this? And the nurse says literally no patient file, no background, nothing. And there's an expectation the practice is just going to do this. So I think that's going to be an interesting space as that grows. So tell me, just AI, when are we going to get Chat GP? So,
I think,
this AI is here. I can just type my symptoms there. Like, we don't need VR GPs. We don't need specialist GPs. The AI is going to do it all. We might as well pack our suitcases and go somewhere else. What do you reckon?
Yeah, well, I think the interesting reality in life is that it's easy for people to think, what jobs will AI take? And the reality is, until AI is registered and has a medical license, guess where the legal responsibility is going to rest? It's going to rest with bunnies like you and I. It's always been that the latest technological weapon plus the expert is better than either alone. And so I think it's just a case of recognizing that, when horses were the mainstay and you're arguing that we should stick with horses and forget cars, or likewise when the internet was new and you're arguing that it was better to stay away from the internet, there are large epochal changes. And so AI is definitely one of those. If we think about it as clinicians and think, imagine being able to offload the cognitively taxing areas of the work we do that don't actually add value to patients. So, for example, trying to fit a consult into the MBS guidelines is bloody difficult. And it's not as if people come in and say, hey, I'm here to have a mental health care plan today. And so I've made an appointment of 25 minutes and I've listed all my things in the framework that the MBS prefers so as that you don't get audited, doctor. That's not how it works. And so it would be really useful to have some passive listening going on that said, okay, you just need to cover these last 2 points. So you could offload the things that aren't actually related to patient care. They're related to making sure that you've met the frameworks around compliance for the MBS. That would be really neat. It would also be really cool if you could say, hey, at the end of the consult, you had a reminder of these people got prescriptions between now and the next visit. Are there any new referrals? Is there any preventative health interventions that we need to make? And they actually prompted you. So rather than you prompting the AI is prompting you as to what you could be doing to cover the interval. I think if we had a layer of excellence that was systemized below the work that we do, which is largely creative and relational, then you could end up with really, really high quality care. It could provide reminders to patients in between consults, could check in on people in between consults. I think there's some really exciting things right on the cusp of realizing. What we do need to do, though, is make sure that we can actually charge for those services. It's probably outside of the MBS framework. It's probably an augmented GP would be the way that I'd be thinking of this.
Thanks, Todd. So today we've covered headwinds facing general practice. In our next episode, we're going to be talking about how we can turn those headwinds into tailwinds and help our boat go faster. I've been Sachin. See ya.
Thank you.
Thanks for tuning in to the Scale My Clinic podcast. I hope today's episode gave you valuable insights and practical steps to take your clinic to the next level. If you enjoyed the show, make sure to subscribe so you never miss an episode. And don't forget to share it with other general practice owners who'd benefit from improving their practices too. Looking for more tools, resources and updates? Why not follow us on Facebook at Scale My Clinic to stay connected to join the conversation with like-minded practice owners. Let's keep working together to scale your clinic and build something truly impactful. See you next time.